Welcome back. If you're enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Today, we're diving into the incredibly high-stakes world of medical coding. Now, you might be thinking this is just about matching words to numbers, but it's so much more than that. Precise documentation and coding are the very engines that drive a hospital's revenue, keep everything compliant, and translate incredibly complex clinical truths into real, actionable data. Okay, let's dive right into our roadmap for today. We're going to start with the DRG blueprint, take a peek inside the grouper engine, and explore the power of sequencing. Then we'll master root operations, tackle a few real-world coding scenarios together, and finally wrap things up with some brand new cardiovascular DRG updates. Section 1. The DRG blueprint. Let's set the stage by laying down the foundational architecture of the Medicare payment system. If you really want to understand inpatient revenue, you have to master this blueprint.
Let's just pause here for a second because this definition is absolutely crucial. What exactly is an DRG? It stands for Medicare Severity Diagnosis Related Group. At its core, it's a statistical system, and its whole job is to classify any inpatient stay into groups that we expect will consume a similar amount of hospital resources. I want you to really lock onto the fact that this classification system is literally the bedrock of the inpatient prospective payment system used by Medicare, as well as a ton of commercial payers.
It all boils down to this elegantly simple equation. Clinical similarity plus resource similarity equals one payment group. That right there is the golden rule of DRGs. We're talking about a system that takes thousands upon thousands of crazy diagnosis and procedure combinations and funnels them down into roughly 750 distinct manageable payment tiers. Section 2. Inside the grouper engine. So, how does that sorting actually happen behind the scenes? Let's use an engine analogy here and take a look under the hood to see exactly how all that raw clinical data gets processed. Think of the CMS grouper as this massive, sophisticated logic engine. Step 1 is feeding it all your raw inputs from the patient's chart. We're talking principal diagnoses, secondary diagnoses, any procedures they had, and basic demographics like age, sex, and discharge status. Then comes Step 2. The engine crunches all of that data and spits out a highly specific output. It assigns a major diagnostic category, or MDC, selects the specific DRG triplet, and calculates the final relative weight, which is the magic number that directly dictates the hospital's reimbursement. Now, what's really interesting about this slide is the triplet structure mapped out here. Let's use heart failure as an example. Depending purely on the secondary diagnosis you capture, you can land way down in DRG 293. That's the lowest severity level, meaning no complication or comorbidity. But watch this. If you capture just one major complication or comorbidity, an MCC, you jump all the way up to DRG 291. That single MCC drastically changes the severity level. It proves the patient required way more resources, and therefore it appropriately bumps up the reimbursement. Section 3. The power of sequencing. Here's the catch though, just having the right codes isn't enough. The grouper engine is incredibly rigid, which brings us to the absolute power of sequencing. You've got to put those codes in the exact right order. Let's put our investigator hats on for a second. Look at the real-world impact of documentation here. If a doctor just writes chest pain on a discharge summary, the coder has no linkage to an acute MI. That kind of vague symptom documentation, it's a fast track to incorrect DRG assignment, revenue loss, and massive compliance risks. But look at the good documentation. It spells out a principal diagnosis of acute anterior wall MI, a specifically linked procedure like a PCI to the LAD, and all secondary diagnosis. Precise, linked clinical terminology is everything. So, the crucial point is that these inflexible sequencing rules dictate what the grouper engine spits out. Rule 1. Your principal diagnosis, the condition established after study to be the main reason they were admitted, is always coded first. Period. Get that wrong, and the entire DRG is wrong. Rule 2, complications of care are secondary. Rule 3, your principal procedure must be the definitive treatment most related to that principal diagnosis. And finally, a huge one, if a severe condition develops after admission, meaning its present on admission indicator is N, it generally cannot count as an MCC to increase payment. It's a strict rulebook. Section 4. Mastering root operations. All right, let's transition over to the surgical side of coding and crack open that 7-character ICD-10 PCS code structure by mastering root operations.
In the PCS system, character position 5 is basically demanding total anatomical precision from the operative report because it defines the exact approach. There are exactly 7 approaches to memorize: open, like a thoracotomy; percutaneous, percutaneous endoscopic; external, natural or artificial opening, natural or artificial opening endoscopic; and finally, percutaneous assisted natural or artificial endoscopic. Your coding has to reflect exactly how the surgeon physically reached the procedure site.
And this brilliantly illustrates why understanding the actual physical tool used by the surgeon is a total game changer. Take a needle biopsy, for instance. If they use a fine needle to aspirate tissue, your root operation is extraction. If they aspirate fluid with it, it's drainage. But if the surgeon swaps that out for a core needle, that larger bore needle actually cuts a physical core of tissue out, which changes your root operation entirely to excision. The tool itself dictates which of the 31 possible root operations you choose. Section 5, Real-World Coding Scenarios. Okay, now it's your turn. Let's put you in the detective seat and solve some tricky, real-world clinical mysteries together.
Here is your first medical mystery. A patient comes in for severe dehydration. While they're admitted, they develop an acute kidney injury, which gets treated with IV fluids. So, is the AKI automatically sequenced as the principal diagnosis just because it's a way more severe condition? Think about the sequencing rules we just went over.
The answer is absolutely not. There is no strict rule saying AKI gets to jump to the front of the line. Clinical coding relies entirely on the documented reason occasioning the admission. Now, if the charts is a little muddy and it's unclear whether the admission was primarily for the dehydration or the AKI, well, that highlights the absolute power of a timely, concurrent CDI query to the physician to figure it out.
Let's move to our second scenario and see how this builds as we layer on some complexity. Imagine a heart failure patient falls out of bed during their stay and fractures a hip. They end up getting an EKG, chest x-rays, medication, and an open reduction internal fixation, or ORIF, surgery. Out of all that, what is the principal procedure?
If you said ORIF, you nailed it. But why? Because when none of the procedures performed actually relate to the principal diagnosis, which remember was heart failure, the definitive treatment for the secondary diagnosis takes precedence. The fractured hip is the secondary diagnosis here. The EKGs and x-rays are just diagnostic ancillary tests, and giving medication is considered uncoded nursing care. The ORIF takes the top spot.
Section 6, New Cardiovascular DRG Updates. Finally, let's shift gears to the latest cutting-edge MS-DRG updates that are specifically impacting high-weight cardiovascular procedures.
Check out this map of the aortic arch, broken down into zones 0 through 4. CMS just introduced a brand new code, MS-DRG 29, for complex aortic arch procedures. This was specifically created to group those highly complex combinations of deploying branched or fenestrated devices right alongside bypass and occlusion procedures in these exact zones. It's highly specific anatomical coding. Similarly, take a look at the sheer intricacy of this iliac branch stent graft. Endovascular technology is moving incredibly fast, and CMS responded with the new MS-DRG 213. This uniquely categorizes endovascular procedures for the abdominal aorta that involve these complex iliac branch devices, making sure the DRG actually reflects the massive resources required for this kind of tech.
And finally, the way we code plaque removal in the coronary arteries has been refined too. We've got new MS-DRGs 359 and 360 for percutaneous coronary atherectomy. What's absolutely vital here is noting the physical tool. You have to know whether an intraluminal device was used, and specifically if it was a directional, rotational, transluminal extraction, or laser atherectomy. The exact device type literally drives the DRG assignment now.
I want to leave you with this somewhat provocative thought. The grouper doesn't read the patient, it reads the coder. All of this highly technical knowledge we just went over, the sequencing rules, mastering root operations, keeping up with DRG updates, it all empowers you. You hold the ultimate key to translating clinical truth into payment reality, completely shaping the financial health of the hospital. So, are you ready to unlock the full potential of your clinical documentation? If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshau. Keep mastering your craft, and I'll see you in the next explainer.